Good morning, everyone. Today we have a special faculty, Dr. Santosh Anand. He is a senior consultant and at Apollo Hospital, Chennai. He worked previously at Jaipur, Pondicherry, and today he's moderating the session. And one of my resident, Dr. Krishna, is going to present the case. Okay, Dr. Krishna.
Good morning, sir.
Good morning.
Shall I continue with the case
Yeah, please
presentation?
proceed.
Yes, thank you. So the patient is a 59-year-old housewife, resident of Jaipur. She came with chief complaints of pain in the abdomen for 7 months, associated with gola formation and altered bowel habits for 7 months. History of presenting illness: patient was apparently normal 7 months ago when she started having intermittent episodes of colicky pain, more in the lower abdomen for 7 months. Initially, the pain was mild in intensity and it was gradually increased to moderate intensity for the last 1 month and increased in frequency. And pain is associated with gola formation with occasional episodes of non-bilious vomitings. Pain aggravates after food intakes, relieves with passage of flatus or stools. And also associated with altered bowel habits for the last 7 months. And patient is also complaining of loss of weight, loss of appetite, loss of weight of around 14 kilos over the last 6 months, which is more than 10% of the patient's body weight, and also associated with generalized weakness. However, she did not give any history of abdominal distension, no fever, cough, evening raise of temperature, or night sweats. Patient did not give history of emetemesis, melena, or hematochezia, no palpitations, no hematuria, no history of body pains, recent onset of headache, or breathing difficulty. Past history, sir, no comorbidity. Patient did not have any comorbidities. She underwent hysterectomy 10 years ago. However, we do not have any documents available, or patient cannot remember the reason for the hysterectomy. She do not have any history of tuberculosis or contact of TB in the past. Personal history: she is a non-smoker, non-alcoholic, no other substance abuse is seen. Sleep and appetite were normal, and bowel habits were altered, and bladder habits were normal. Family history: there is untimely death of the patient's father when the patient's father was 25 years old. Reason the patient don't know. And patient also have history of colonic malignancy for her son. Her son got operated for colonic malignancy at age of 30 years. So summarizing the history, she is a 59-year-old housewife without any comorbidities, with a significant history of family history of malignancy, came with complaints of progressively increasing colicky abdominal pain, more in the lower abdomen, associated with gola formation, associated with non-bilious vomitings, which is aggravated with food intake, relieved after passing flatus and stools, and associated with altered bowel habits, and associated with loss of weight and significant loss of weight, generalized weakness, not associated with emetemesis, bleeding PR, or melena.
So, out of curiosity, what is gola formation?
Round, it is a spasmodic pain that typically in the northern India they complain like gola.
Okay. And can you just elaborate the altered bowel habits?
So patient is giving alternating episodes of
your voice is getting interrupted in between.
Alternating episodes of constipation and diarrhea, sir.
No, in this patient.
In this patient only, sir. She is giving history of occasion. Sometimes she will give history of constipation and but gives history of diarrhea. Which alternates.
Okay, I would suggest to say this in a way that this was a routine previously. Now, over this much period, she is passing this many number of times stools, this much liquid quantity of stools, which is alternating with this many number of stools, and this is the quantity of or consistency of the stools. Okay, that would elaborate the altered bowel habits. And definitely there is a significant family history. So, what is your differential diagnosis based on your history?
Sir, my first differential diagnosis is a malignancy. I would think more in favor of colonic malignancy, sir. Left colon.
Okay. And any other TD?
Sir, yes, sir. It still can be a malignancy of the right colon also. and any IC junction tumor.
Okay. So you have brought in three things. So one is malignancy, number two is colon, number three is left colon. So can you say features in the history which are favoring malignancy?
Sir, one, patient's family history with significant family history. Next is patient's age, and third, sir, the significant loss of weight and loss of appetite with generalized weakness.
So this is
Hello.
for malignancy.
Yes.
Okay. Number two, what are the features favoring colonic malignancy in this patient?
Alternating constipation and diarrhea is the one which is favoring colonic malignancy in this patient. And
Okay.
again, the family history is also the family history where the son had a malignancy, colonic malignancy. Specifically, they are saying that the son had suffered colonic malignancy.
Okay. And what is the feature favoring left colon malignancy?
The alternating diarrhea with loose stools.
Okay. So why could it not be inflammatory bowel disease like Crohn's disease?
Sir, it can be, sir. It can be. Yes, sir.
Why could it not be tuberculosis?
Sir, no history suggestive of tuberculosis in the past. No contact, and with positive family history, it's very unlikely to end. No fever or no symptoms, no systemic symptoms of the
So
patient
how
is not
frequently
having.
do we get all those systemic symptoms in ileocecal tuberculosis?
10%. It's very less, sir.
So can that be a differential diagnosis too?
Yes, sir. It can be a differential diagnosis. Tuberculosis can also be a differential diagnosis.
Okay. So I think right now we can come to syndromic diagnosis of malignancy, then colonic malignancy because of significant history. But it's always better to include a differential diagnosis down the line, saying that it is less likely, and justify that, saying that these are the positive things, these are the negative things. Because we do have some positive things for ileocecal tuberculosis. It can occur in any age. In India, it can occur in anyone. We need not have systemic symptoms for ileocecal tuberculosis. It can be associated with altered bowel habits. It can be associated with significant weight loss, generalized weakness, all those things.
Yes.
Okay.
Yes.
And did you ask for any rectal symptoms?
Sir, I asked her specifically, like whether she.
Tenesmus?
Yes, sir. I have asked her. She said she did not have any tenesmus. She did not have
Okay.
any at least
Okay.
to pass stools or any other thing.
Okay. So what is tenesmus?
So incomplete sense of evacuation of stools is tenesmus, sir.
You should add the word painful.
Okay.
Okay, that is tenesmus.
Okay, sir.
Painful sensation of passing stools with a sense of incomplete evacuation. So, what is urgency?
The inability, I mean, like urgency, like patient can't hold on for long for the stools. Yes.
Okay. And fine. This colicky abdomen pain, is it common in large colon malignancy or is it common in small bowel obstruction?
More common in small bowel obstruction, sir.
So, is there a feature which differentiates from the history that it could be a colonic obstruction rather than a small bowel obstruction?
Yes, vomitings, the nature of the vomitings. In a small bowel obstruction, patient will be having bilious vomitings.
Okay.
Yes.
And what happens in colonic obstruction?
And the pain relieving after vomiting is more in favor of the pain. Small bowel obstruction, the patient will give the pain reliefs is more after vomiting.
Okay. And depending on the site of the pain?
The typical left colonic obstruction, the patient will have the pain more in the lower abdomen. Whether small bowel obstruction, it is in the periumbilical region.
Exactly. So these are the features which differentiate between the small bowel obstruction and large bowel obstruction. And one point favoring in your patient is she gets relieved of pain after passing flatus and stools. Now, why there is an alternating diarrhea and constipation in this patient based upon your first DD of left colon malignancy?
The obstruction before, because of the obstruction, there is constipation. Once the pressure is more in the proximally, it relieves in the form of sudden loose stools, multiple loose stools. So that explains it.
Okay. And is that the only mechanism behind that?
And more mucus gets secreted and gets collected in the proximal also.
Okay. So what is the prime function of colon?
Absorption of water is the prime function.
So only the secretion of mucus will explain you, despite excess absorption of water, there is diarrhea. Okay, if you don't say mucus, then it will be constipated only, there won't be diarrhea. So in order to overcome that, there is excessive mucus secretion. Okay, fine. So can we proceed to examination?
Yes. So general examination, patient is conscious and oriented. She is moderately built and nourished with BMI of 27 and ECOG 1. Or she has pallor, no icterus, no left supraclavicular lymphadenopathy or pedal edema, no clubbing or cyanosis. She is well hydrated and she is hemodynamically stable, sir, with pulse of 88, BP of 130 by 78. She is afebrile and saturation of 100% at room air.
You can proceed to next.
So coming to the local examination, inspection of the abdomen. Abdomen was flat, umbilicus is central and inverted. Lower midline scar was present, which was of the previous hysterectomy. No fullness, no sinuses, no dilated veins, no visible peristalsis or pulsation seen. All quadrants moving correspondingly with respiration, and hernial orifices were normal. On palpation, the inspectory findings were confirmed. No local rise of temperature or tenderness, though discrete mass palpable. Hernial orifices were normal. On percussion, the liver span is 14 centimeters in the right midclavicular line from the fifth intercostal space. There is no ascites. Auscultation, on auscultation, bowel sounds were increased, exaggerated. The digital rectal examination, the fecal staining was present, sir. No melena or bleed was there. There is no palpable mass or palpable nodules on DRE. The CNS, CVS, and RS respiratory systems are essentially normal.
Can you summarize both?
So she's a 59-year-old female with a positive family, without any comorbidities, and positive family, significant family history of malignancy. Came with complaints of colicky abdominal pain in the more in the lower abdomen, associated with gola formation and occasional vomiting, with symptoms relieving after passing flatus and stools in the last 7 months, with his loss of weight, loss of appetite, and generalized weakness for last 7 months, without any hematemesis and hematochezia or bleed, melena, with no positive findings on general examination, with pallor on general examination, and no other positive findings on local examination or yes.
So except for pallor, examination has not added to your history.
Yes.
Okay. So what is your differential diagnosis based on this?
Sir, for my first differential diagnosis is malignancy, colonic malignancy being the first one. Next is ileocecal tuberculosis, second, and third, inflammatory bowel disease.
Okay, so inflammatory bowel disease, what inflammatory bowel disease?
Sir,
it could not be ulcerative colitis, right? There is no bleeding PR or
yes,
diarrhea. So you can say inflammatory bowel disease, probably Crohn's disease.
Crohn's.
So what age group does Crohn's present?
Sir, it is bimodal, whether it is young.
So what are the two age groups?
Sir, one is around the adolescence age group, and second one is 50 to 70s.
So second decade and sixth and seventh decade.
Yes.
So she falls within the second decade. I mean second bimodal age. Okay. And in digital rectal examination, did you find anything else in rectum?
No, sir, no ballooning of rectum.
Was there a ballooning of rectum?
No, sir.
There was no ballooning of rectum. Now, why I am particularly asking this question?
Because of obstruction, there will be a ballooning of rectum.
Okay. So in obstruction, why does rectum balloon?
No, sir, I am not aware of the reason.
But you would have noticed, no?
Yes.
Both in digital rectal examination, both in CT, everything you would have seen.
Yes.
So what is the mechanism behind, and in which condition this is more?
Which condition it is more?
Obstruction, particularly, the market ballooning will be more in the left colonic obstruction. See, the reason behind this, again, it's a mechanism, a body's reflex. According to rectum, something is there in the left colon. Okay, it can be a mass or it can be anything, but it senses it as a stools.
Okay.
It prepares itself to receive large amount of stools. That's why it balloons. Okay, and I just saw the general examination. Her BMI is 27 and weighing 70 kilos, which means she was an obese patient before.
Previous years. Yes, sir. She was an obese patient.
Okay, fine. So, how will you, proceed next? What investigation you wish to do?
Sir, I would like to get her CBC to look for her hemoglobin level and other blood investigations, complete hemogram, liver functions, renal parameters. I would like to see, and electrolytes. And specifically, I would look like for her serum albumin. After the blood investigations, I would like to go for a colonoscopy, sir.
Okay. And do we have any blood investigations with us?
Yes. These are her blood investigations, sir. On blood CBC, it had showed hemoglobin on the lower side. It is 7.9. Renal parameters were within normal limits. Liver functions were also normal except for albumin, which is slightly on the lower
What
side.
was the total protein level?
6.9, sir.
Okay. So there is reversal of albumin globulin ratio too.
Yes.
Despite her preserved weight, like weight loss is there, the weight is preserved. Okay. You didn't mention CEA in the blood investigation, but it has been put out here.
Because after colonoscopy, we will go for CEA.
So why directly colonoscopy?
Sir, because of her.
You not wish to get an ultrasound scan before?
So more than ultrasound, I would have gone for an X-ray. I would like to see the level. I mean, patient is typically giving history of obstruction intermittently. So
X-ray abdomen, would you do it prior to colonoscopy?
yes, sir. Prior to colonoscopy.
Do we have an X-ray?
Sir, no, sir.
Okay,
Patient
fine.
didn't get an X-ray.
So
Patient directly came with a CT scan.
would you wish to admit the patient?
Yes, sir. Ideally, the patient should be admitted.
And what is the reason for admitting the patient?
Once the patient gives he is not able to eat properly also was the first reason. Second, the patient occasionally is also having vomitings. So just admit her for supplementation.
Would you prepare this patient before subjecting to colonoscopy?
Yes, sir. She needs also preparation also, colonic preparation also she needs to be having.
So with the background of partial or intermittent obstruction, when you subject the patient for bowel preparation, sometimes they may go in for complete obstruction also. So that is one reason. And that is one essential reason why you do an X-ray abdomen also.
Yes.
Okay. So again, dicey situation, sometimes few examiners may prefer a CT scan before a colonoscopy because claiming that she's obstructed and I can do well without colonoscopy also, just giving a enema and then proceeding with sigmoidoscopy. But ideal would be doing a colonoscopy that you can justify by telling that I would wish to admit the patient and give preparation under observation. Okay. So what you wish to see in colonoscopy?
Sir, I would like to have a full-length colonoscopy, and in the colonoscopy, I would see the pathology.
Just a minute. Sorry to interrupt. What preparation will you give for colonoscopy?
Peglet.
Okay. And how will you? How long before colonoscopy? What time you give?
What time I'm
In the
not
sense, how
exactly
how
sure.
how much before colonoscopy? Like you are planning to do a colonoscopy today morning at around 11 o'clock.
Yes, sir. Sir, at least 6 hours before that. At least the patient should pass 6 to 7 stools before the colonoscopy.
And consistency of the stools?
Should become watery, sir. Should be
So it
watery.
should be a clear liquid
Clearly.
when they pass stools.
Yes,
Okay.
sir.
So any other alternate method of preparing bowel?
Yes, sir. They, I mean, enema, multiple enemas that we can give to the patient also. That is one
What
way we can.
enemas?
Enemas, sir. Phosphate enema.
Okay. Any other way of preparing for colonoscopy? For sigmoidoscopy?
Yes, sir. Just enema, phosphate enema is sufficient. Only for if we are planning only for sigmoidoscopy, phosphate enemas are sufficient, and we can take up for sigmoidoscopy.
Okay. Now, sorry. Are you going to achieve? Okay, fine. Now tell me what all things you will be seeing in colonoscopy. Then I will ask the subsequent question.
First of all, I would like to see the if any pathology is there, what the site of the tumor, the site, the extent of the tumor, and any other lesions or other lesions are also there. If it is a single lesion or a multiple lesion, the whole length of the colon has to be examined in this patient, and biopsies.
Negotiability.
Negotiability.
Okay. Any difference between what is a significant advantage you get by doing colonoscopy rather than a sigmoidoscopy?
We can examine the rest of the colon also. No? We can get rest of the colon is examined. Any polyps or any other lesions are there or can also be identified.
Okay. How many patients, percentage of patients you get synchronous polyps, and how many patients you get synchronous tumors?
5% or less, sir.
Now, my question, I asked two questions: synchronous polyps and synchronous tumors.
For polyps, I'm not sure, but synchronous tumors, less than 5%.
Synchronous polyps can occur as high as 8 to 12% with the significant family history. What age did her son who developed the malignancy? What age did he
30,
develop?
30 years, sir.
Okay. So, though it's a significant family history, isn't it the other way around? Like mother getting malignancy at 60 years and son getting it maybe 40 to 50 years. 30 years, would you still think it's could be a genetic or familial cause?
Yes, it can still be a genetic cause.
Having said that, now this woman's age is 59 to 60.
Yes, sir.
So if you want to leave out this patient, if you want to advise for family screening for any other patient with similar age without family history, what time will you advise her siblings or her daughter or son to start screening colonoscopy?
From 20 years of age. Second decade, they have to start screenings.
Are you sure? Like, what does the routine recommendations say? So there is a difference between starting a screening colonoscopy for a solitary lesion, and there is a difference in screening colonoscopy for one who has multiple polyps
Okay.
and malignancy from the polyp. So the usual recommendation for one who has a solitary tumor is 10 years before the age of presentation. So that's the standard recommendation.
Yes.
Okay. Do we have a colonoscopy now?
Yes. We have only a sigmoidoscopy, sir. It was done outside. They have seen a nodular proliferative growth, which is seen 10 centimeters from the anal verge, which the scope is negotiated easily. And the biopsy have shown well differentiated adenocarcinoma, sir.
Okay. They have not mentioned anything about proximal, though they have negotiated.
They have not mentioned. They have mentioned it was easily possible.
Okay. So anything is missing in this?
Yes, sir. Upper border, they have to see how long the lesion is. Second, they should have done a full length colonoscopy.
Okay. So now what do you wish to do?
Would like to get a full length colonoscopy. Ideally, we should get a full length colonoscopy. Should be done.
Okay. For what reasons?
One,
Other than
we can,
the upper length and getting other synchronous polyps or tumors.
other than this, no, sir. Other than synchronous lesions,
So 10 centimeters from anal verge means essentially it's a
mid-rectal tumor. It will come in the mid-rectum.
okay. And is there a difference between the management or the ease of management depending upon which quadrant of the rectum the tumor is placed?
Ease of management.
Like anterior or posterior? Is there a difference?
Yes, sir.
What is the management difference?
It's whether it is a posterior tumor or an anterior tumor. So in this case, we have to go for low anterior resection. In this case, surgery will be.
Oh, you mean to say that anyways we are going to do low anterior resection. So whether the tumor is placed anteriorly or posteriorly is not going to change my management. Okay, fine. We will come back to this when we discuss in detail regarding management. What have you done next?
Sorry,
Hopefully, what have you done next? Like probably would not have done a colonoscopy for logistic reasons.
yes, sir.
Okay, so how would you? Okay, in diagnosis, what are the three things? Basically, divide your diagnosis into three things. So the first thing is confirm the diagnosis, which you have done. Okay.
Yes, sir.
Second is to stage the disease.
Stage the disease.
So now, how would you stage the disease?
Sir, in this patient, we require a CCT of abdomen and chest, abdomen, HRCT of chest, CCT abdomen and pelvis, and along with that, MRI of pelvis also has to be done.
Okay. Now,
This is for
why MRI of pelvis?
sir, one, it will give a better anatomical detail compared to CT scan because it is in the mid-rectal tumor. And the surrounding structure, and we have to see the surrounding structures or involvement also in this case.
See, simply I will say that, sir, I'm going to get a very good CT abdomen, chest and pelvis. So I would not wish to do an MR. Am I doing an ideal thing or not?
No.
Why?
MR will give better anatomical delineation, nodal status.
What
and
are
these
the
things
anatomical delineation you would wish to see in MR?
The nodal status and
Nodal status can be seen in CT also. So what is mercury trial? So what is it regarding? Okay, fine. Mercury trial is something to say about the role of MR pelvis rectal sequences in rectal cancer patients. Okay, so just go and read that. But in short, it tells you about mesorectal fascia, MRF, involvement of vessels like lymphovascular invasion, small nodules which are present within the MRF. All those things can be seen in case of upper and mid-rectal tumors. In lower rectal tumors, definitely MR has got a better role than CT because it could differentiate very well about the sphincter's involvement of internal sphincter, involvement of intersphincteric space, involvement of external sphincter. All those things are better seen or definitely better seen in MR rather than CT abdomen.
Yes.
Okay. So, conventional question. Before subjecting to MR pelvis and CT abdomen, I say I would just get an chest X-ray and ultrasound abdomen. So, do we have anything to support that or refute that? It's a conventional question. Like, with due respect, senior surgeons will definitely ask this question.
Yes, sir. To look for one metastasis, whether lung metastasis or any liver metastasis, ultrasound is good enough to pick up there are any metastatic deposits in liver. HRCT is superior, definitely superior to chest X-ray, but some people do prefer chest X-ray to HRCT of chest, sir, for
So
metastatic workup.
that's what I asked you. You should say something to support and refute also. So, I mean, a safest answer would be like before telling HRCT chest, abdomen, and pelvis. You can say that I would wish to get a chest X-ray and ultrasound abdomen initially, and then if they ask whether this will do, you can substantiate. Sir, if it's an advanced lesion, with this, the patient may be subjected to further treatment, but the pickup rate of the CT is much better than the ultrasound scan and chest X-ray. So I would prefer that.
Yes.
Having said that, will you get a PET CT or PET MR in this patient?
No, sir.
Which has a much higher sensitivity.
PET MR I have never
PET
heard
CT or PET MR, like PET scan for that
scan.
cases. Is it an indication for PET scan, or is it not an indication for PET scan? No means why no?
Sir, first of all, in colonic malignancy, the pickup is lesser. For PET scan, it is lesser, sir.
Pickup rate of what?
The words.
PET scan essentially means I'm going to combine it with PET CT or
Yes,
PET
sir.
MR, like in places
PET
where it
CT.
is available.
But
So
the tumor uptake of the PET is the less in colonic malignancies, sir. More, it is lesser in colonic malignancies.
is it true? Is it less than colonic malignancies?
Yes,
Probably we need
it
to
is
check it.
okay.
Okay. So unlike hilar cholangiocarcinomas or specific subgroup of adenocarcinomas like mucinous or signet ring cells and HCC, well differentiated HCC, only these three conditions the uptake is poor. In other conditions, the PET uptake is good. Okay.
Yes.
But the thing is, in PET CT, we are going to concentrate more on metastasis rather than primary or the nodal status. For primary and nodal status, our preliminary investigation is either CT or MR.
Yes.
Okay. Now I'm going to do a PET CT. So can I combine both nodal and primary status along with metastatic status? I'm telling sir, I'm going to get a very good PET CT, which can tell me about nodal status, primary status, and metastatic status also. Single scan, I can very easily convince the patient. Now, what are the disadvantages of that?
Disadvantages, the image resolution is lesser in the PET CT, sir, compared to other CT scans.
And what is the reason for that?
I'm not sure about the reason, sir, but
because the CT scan which you include in the PET usually are less than 6 or 8 slice CTs.
yes,
Rather than the routine CTs which we get usually these days are more than 16 or 64 at least. We have 640 slice CTs also.
yes.
Okay. So that answer you should be definitely aware of. And in NCCN also, PET CT is not routinely included in colonic malignancies. But is it the same for colorectal liver metastasis also?
No, sir.
So there PET becomes an essential one.
Essential.
Do we have a PET or MR in this patient?
Sir, we have only a CECT scan. Film child shows, sir. So this is a CT scan of abdomen with only rectal contrast. It is not a good quality of MR.
Do we have like cine view or only pictures? Like packs, do you have packs or only this?
No, sir. This is an outside one, sir.
Outside. Okay,
so
fine.
we don't have it. This is a very poor quality of CT scan, where we can see a long segment thickening, sir, starting from here. So this is a long segment thickening of from the rectum, we can see there is a heterogeneous lesion which is filling into the lumen of the rectum, sir. You can see in this, which is extending 6 centimeters more up to up to the sigmoid. We can even see up to the sigmoid.
Okay, how did you come to a conclusion that 6 centimeters?
Sir, I have counted the number of slides: 1, 2, 3, 4, 5, 6.
And is it 1 centimeter or 0.5 centimeters?
It is 1 centimeter.
1 centimeter. It's mentioned there.
This one number of slides.
No,
So
probably he's wrong, Dr. Santosh.
yeah. Better not to
The
say
slice
the
interval we don't know. There's written
it's
always
better
the slice
not to
interval 1
say
centimeter,
the
2
centimeters. Rather than you can start saying that it is from rectum or mid rectum till the sigmoid, which you can interpret from the surrounding structure presence. Okay, or you can count from maybe the level of spine. Okay, S2, S3, and then going till best will be to say that it's from mid rectum, which you can say by starting just above the this thing, puborectalis.
Yes.
So here, this one, I don't know whether my mouse is pointing there. Third one in the next row, you can see puborectalis starting there. So above that, go proximally is the mid rectum. So mid and upper rectum, and then above the sacral promontory also the thickening is extending. So it's a mid rectal growth extending proximal to the rectosigmoid junction and maybe distal sigmoid. So what are the other things you are seeing in the CT?
So we should see for nodal, any nodes or any infiltration into the vascular structure and regional infiltration, which it is not. We couldn't see any nodes also, sir. It's not a good quality of CT scan.
Please don't repeat that it's not a good quality CT every time when you say.
Okay, sir. We couldn't identify.
It's not for my sake. In exams, you should not keep telling this again and again. Not a good quality CT. Okay. So in this CT, you are not able to appreciate notes. But could you trace where the IMV, IMA, IMV is there in this patient? Do you find any notes there? IMA.
No, sir. Trace also.
Yes. You can concentrate on the last row.
Yes. Sir, I'll enlarge the image.
Okay, fine. That's becoming difficult. Leave it. Not an issue. You can proceed. Okay. No, that's fine. It's becoming a bit difficult for you.
Yes.
Okay, fine. Dr. Krishna, that's fine. That's fine. What else you are seeing? Like appreciating notes are becoming difficult, but certain things you can appreciate very well easily. What are the things you are appreciating easily, even if they are negative findings in the CT?
There is no ascites we can see, sir, or no liver deposit, metastatic deposits in the liver we can see. There is only a small tiny cystic lesion in the right lobe of the liver. However,
better not to comment as a cystic lesion in CT. Cyst is better appreciated either in ultrasound scan or MR. Here you can say an hypodense lesion, small hypodense lesion, which is present in the probably segment 7 or 8. Now, how could you say that it is segment 7 or 8?
Ideally, we should have the hepatic veins, and it is above the portal vein bifurcation.
Yeah, that's all. It's on the right side. It is above portal vein bifurcation. So it's either segment 7 or 8. Now I'm saying that this looks like a metastasis for me.
Yes.
How would you proceed?
We should go for an ultrasound and then evaluate the lesion in this, or an MR in this patient.
Which is better?
Ultrasound is better, sir. We can go for biopsy also if we have any suspicion?
Such a small lesion, okay. For appreciating a liver SOL, which is the best scan possible?
It is in liver as well.
So this is a liver SOL, right?
Yes, sir.
So the only advantage of ultrasound scan is you can take an FNA if at all required, though it's an invasive procedure. But I would rather prefer to get an MR or PET CT. Only disadvantage of PET CT is such a small lesion, 0.5 centimeter or less, the PET uptake may not be so great. Okay. Will you give a rectal contrast in such patients?
No, sir.
While taking CT?
We need to give
IV contrast.
Sorry, sir.
In addition to IV contrast while taking CT, will you give rectal contrast also?
We need to give negative contrast to distance the.
So what are the negative contrast, you know?
Water, mannitol we can give, water or mannitol.
Okay, you can give methyl cellulose also.
Methyl cellulose.
Have they given something?
So yes, sir. They have actually given nothing. Sorry, nothing, sir.
You're seeing something in sigmoid colon. You are seeing something in the transverse colon.
It is a distended proximal bowel loop with lot of feces, sir.
Okay.
It is actually
those transverse colon in the previous picture, they were also not contrast. The distal transverse colon kind of. Okay, fine. So the additional finding you are seeing here is loaded colon till cecum.
Yes, sir. It's
and
loaded.
No small bowel obstruction.
No, sir. No small bowel obstruction.
Ascites and visible lung fields. We are not seeing any SOL in that also.
Yes, sir.
So how would you proceed in this patient?
Sir, first, ideally we should get an MRI of pelvis in this patient along with HRCT of chest to look for any metastatic deposits, and we had nodal status and lymphovascular invasion status. We will see on MRI pelvis. Then we will have to work up with the patient for surgery. If they both are negative, then we will have to work up for surgical workup. Then we have to go for surgical workup.
Okay, this patient in MR, you are seeing a growth which is crossing the muscular layer, entering into the mesorectum, but the mesorectal fascia is not threatened.
Yes.
It's more than 5 millimeters. You see lymphovascular invasion, probable lymphovascular invasion present. And in MR, few mesorectal nodes are also present.
Yes, sir.
HRCT is negative for lung nodules.
Yes.
How would you proceed?
Sir, I would directly go ahead with the surgery in this patient. We can go ahead with surgery in this patient, sir. Low anterior resection.
So, I would prefer to give radiation for this patient, neoadjuvant chemo radiation for this patient. So, just tell why I am wrong or why I am right.
Mesorectal fascia is not, even though the nodal status is positive, the rectal nodal status is positive is an indication for radiotherapy.
Beyond CT3. It is beyond CT3. N plus.
N plus is an indication for radiotherapy.
It's an N plus more than CT3 disease. Yes, so I am telling I will go for neoadjuvant radiation.
Yes.
So you told you will go for LAR.
I heard it wrongly, sir. Nodal status negative, I heard. I am wrong. Nodal status positive is an indication for radiotherapy.
And more than CT3? With
more than CT3%. Yes, sir. That is also an indication for neoadjuvant radiotherapy.
So what is T3, T4 based on MR?
Based on MR? I'm not sure, sir. Based on MR, I'm not sure, sir.
So you can just go back and read that. What is mesorectal fascia? What is threatened mesorectal fascia? What is T4A, T4B? More than T3. I specifically said it has crossed the rectal wall and entered into mesorectum, but the mesorectal fascia is not threatened. Okay. So that makes a difference. Now you have a justification to going for upfront surgery also. What is the justification?
In this case, sir, yeah.
In the present scenario, like I have told, it's CT3 N plus.
Upfront surgery, I'm not sure, sir. But I'm not sure, sir.
Okay. So this seems to be a long segment growth with partial obstruction.
Yes, sir.
Okay. So while giving radiation, the patient may go in for complete obstruction also. So how would you prepare the patient before that? So, or at least what would you recommend for the patient?
Change in the, I mean, we will advise change in the dietary habits of the patient. Now, the normal diet, we will more of a semi-solid diet, so liquids, more of liquids in the diet. That is
Okay, I
what.
will give you a scenario. Same patient has presented with a frank obstruction.
Yes, sir.
So what will you do? Like in
Then we
MR,
have,
same T3 plus N plus rectosigmoid growth extending to mid-rectum.
yes, sir.
What would you
In
do?
that, then we have to take up for a surgery directly. Upfront, we will take up for surgery, sir. This, sir.
Any other possibilities like options?
There are other options also. Endoscopic stenting is also one option, sir, to
Mhm.
temporarily relieve of the patient of the obstruction.
The other option? Which is most commonly followed. You divert the patient, subject them for neoadjuvant chemoradiation, and then do a surgery. I think that is the most commonly followed in India due to logistic and financial reasons. So, having said that, will you be able to stent this patient?
No, sir, it is a very long segment growth. In this patient, it is very difficult to
Okay,
stent.
one is long segment growth. What other thing is against stenting in this patient? The location of the tumor, it is extending into the mid-rectum. So the distal 2 to 3 centimeters of the tumor, if it is crossing anorectal margin, the stent migration rates are very, very high. And the patient may not tolerate, will have a severe tenesmus. So the safe answer would be I would divert the patient, subject them for chemoradiation, and then do an possible resection.
Yes.
Okay. What are the agents given in chemoradiation? What are the courses you know? Neoadjuvant treatment.
Sir, 5-fluorouracil.
What are the regimen you know? In neoadjuvant treatment.
Folfox regimen we will give, sir.
Okay. Probably, I think you may need to go and check it out. So, what is the standard short course radiation? What is the standard long course neoadjuvant chemoradiation? What are
Short
the
course radiation is 25 gray, which is given in 5 cycles.
okay 5 cycles or 5 fractions?
5 fractions. Sorry, sir. 5 fractions.
Over
Whether
5
it is
days.
yes, sir. Yes, sir. Over 5 days. In long course, it is 50.4 gray in 23 fractions. Sir.
45 is given as 1.5 fraction, and remaining 5.4 is given as local boost. Do you add any chemotherapy agent in that? In long course radiation?
Long course radiotherapy, yes, sir.
What chemotherapy agent do you add? You just told that.
5-fluoro.
Yeah. You add either 5-fluorouracil or it's oral tablet. Capecitabine. Now, what is the role of 5-fluorouracil or capecitabine in long course radiation?
They are radiosensitizers.
So they are not actual chemotherapies.
Yes.
Okay. So the standard recommendation for stage 4 and stage 3 disease. Stage 4, you use Folfox unless it's total neoadjuvant therapy or something. Okay. So you use only long course chemoradiation. In that, you don't add oxaliplatin or irinotecan. Now different regimens have come. Please go and read about total neoadjuvant therapy and sandwich therapy, which is short course radiation followed by interval chemotherapy. You should be aware of these two also. Okay. And what is the advantage of giving radiation in neoadjuvant status rather than in adjuvant status? See, you could justify saying that, sir, I would do an upfront LAR and then give adjuvant chemoradiation.
Yes.
So what is the disadvantage of giving adjuvant radiation?
Disadvantages of adjuvant radiation.
Or the other way around, advantages of neoadjuvant radiation.
Neoadjuvant, better local control will be there compared to the adjuvant setting. But the only thing is the difficulty in the intraoperatively, it will, because of more fibrosis, it will be difficult. That is a disadvantage of a neoadjuvant radiotherapy.
See, the advantage is, as you said, better local control. Number two, number of people completing the radiation is more in neoadjuvant setting rather than adjuvant setting. You can avoid small bowel radiation enteritis also in neoadjuvant setting rather than adjuvant setting. Okay.
We have 5 minutes now, for Santosh.
That okay. It's 9:56 now. What is Stockholm 3 trial? I mean, I'm just slightly going to beyond that. Stockholm 3. Just read about that also.
Yes.
Fine. So coming back to surgical portion, you told LAR. What are the steps of LAR?
Sir, first of all, first we'll do for a staging laparoscopy. We'll identify, and look for any
Will you
metastatic.
prepare the patient for LAR?
Yes, sir. No preparation. No bowel preparation.
Any specific reasons?
Sir, anastomosis is more like more likely to leak if the bowel preparation is done.
More likely to
leak.
Okay.
Second, more.
Okay. Two things are there. You can read the Cochrane database for left colon tumors and rectal tumors. For bowel preparation, lap versus open.
Yes.
Okay. So read the Cochrane database. It is slightly older study. And you can read the recent studies regarding preparation in Indian patients for left colonic and rectal malignancies, particularly in laparoscopy. Okay, you have to read these two so that you can substantiate whenever question comes. Go and read both Cochrane database and recent Indian studies for preparation in left colon and rectal cancer, subjecting them for lap or open layer. Okay, fine. You have prepared or not prepared the patient. Position, then staging laparoscopy.
Yes. Modified
or you can use the word Lloyd Davis or low lithotomy. You can say low lithotomy
position.
So why low lithotomy? Why not complete lithotomy? Any advantage of low lithotomy over conventional lithotomy? Anyway, you will be going to do anastomosis from below. No, if you have a conventional lithotomy, it will be easier for you to access anus and rectum. So when the legs are high, no, the area of freedom when you operate in the abdomen becomes less.
Yes.
Particularly if it is laparoscopy, your instruments will start hitting. You may not be able to reach there. Okay. Fine. Position, low lithotomy, and what position of the patient? Like intraoperatively, you ask for any position change. Head.
Head low, sir.
Okay. So you will give some support for the patient.
Yes.
What support?
The shoulders should be supported so that the patient should not slide down.
Okay. And in shoulder support, it should not be hard support. It should be soft one. Otherwise, hard support. An obese patient operating for 4-5 hours can lead to brachial plexus injuries.
Yes.
Okay. So preparation, positioning, support for positioning, and any other things you will add to the legs of the patient.
Yes, we need. Yes, sir. We need to. Pneumatic pumps should be given one, and support should also be given. Soft.
Add these things before you tell staging laparoscopy. See, ultimately we are going to do all those things, but these will give additional favoring points for you. Okay. In staging laparoscopy, what are you going to see?
Sir, one, whether there is a present of any deposits, peritoneal deposits, omental deposits, or any liver lesions are there or not. Second, ascites is there or not. We have to see, and that's all.
Okay.
Yes.
what would you prefer, open or laparoscopy?
Staging lap is a lap, sir.
No, not diag lap.
Sorry.
While you proceed, how would you prefer, like laparoscopy or open?
Open.
Okay. So is there a difference between the steps to proceed for LAR while doing laparoscopy or open? So, okay, tell me the steps of LAR.
So once we will go from medial to lateral way. First, we will have to sorry, not it. Below the rectum, we will open the peritoneal folds till the lower peritoneal fold we will open, and in the mesorectal fascia we will enter the mesorectal fascia, and in the mesorectal fascia without any breaching we will have to with sharp dissection. With using sharp dissection, we will have to go from medial to lateral, and after that the sigmoid colon is also mobilized. Mobilization of the sigmoid colon also, and below the peritoneal fold. And inferiorly below the peritoneal fold, we will have to go below the peritoneal folds in this case. And once it is done, we will have to completely mobilize the left colon also completely has to be mobilized to see the for the anastomosis. It should be a tension-free anastomosis. So if needed, even the splenic flexure mobilization has also to be done. Yes, sir. And after that, the proximal and distal margins of the tumor we have to assess. Proximally around 5 centimeters and distally 2 centimeters of margin is required. We'll have to make minimum 2 centimeters of margin, and then we will have to resect the tumor and then go for the anastomosis. It's a proximal diversion I'll use too.
Okay, 2 centimeter distal margin, is it mandatory in a post neoadjuvant setting?
It is depending upon the grade of the tumor. Well differentiated, it is even 1 centimeter is also enough. If it is well differentiated, it is 1 centimeter is also enough.
So I'll give a situation. It's a poorly differentiated tumor. I have given a total neoadjuvant treatment, but I'm having only 1 centimeter margin. Is this justified?
It is enough, sir. We will send for the frozen section of this margin. We will even send for the frozen. Not 1 centimeter is also enough, sir.
Okay. Whether to send frozen or not is again debatable. So basic difference between laparoscopy and open is medial to lateral mobilization. That is number one. Number two, splenic flexure mobilization is preferred being done before proceeding to rectum in laparoscopy because of a change in the position. Okay, so these two things, just remember whenever they ask, medial to lateral and splenic flexure mobilization comes initially. Okay.
I think Dr. Santosh
this is beyond something.
Yeah, it's beyond 10. So, first of all, I want to tell about Dr. Santosh. Dr. Santosh has so many videos on the YouTube. He's running his YouTube channel on the YouTube channel, having so many of the laparoscopic videos he have. You can tell regarding your YouTube channel also to our residents or the faculty members.
I hope it's not an advertisement kind of thing.
No. You can tell.
Basically, that YouTube channel is purely teaching kind of thing. Only technical. You will never find my photos there. Only my voice will be behind. And I would have possibly justified by telling each and every step how to proceed, starting from surgeries like hernias till surgeries like laparoscopic Whipple's procedure, laparoscopic hepatectomies. And I hope that may give you idea both in laparoscopy and in open, because the anatomy which we see in laparoscopy is, I believe it gives me a better understanding of the anatomy while I go for surgery. So even for beginners, those who have just assisted minor surgeries, you are planning to go for major surgeries, you can view this videos, and definitely that will help you out a better understanding when you go to any major surgeries like Whipple's procedure or all those things. So it is in the name of Santosh Anand SG only. You can put as laparoscopic Whipple's Santosh Anand, you will find that.
You can send me a message. I will put it in on our group. I will add you in my group also. Our group is Jaipur Surgical Tutorial. Okay. So in the meantime, I will inform you regarding any further cases or further class from your side, and we'll plan on a video session further after that. One of you will directly presenting the video, and we'll have some question answer discussion.
Definitely, and thanks for the opportunity. That was privilege. I do take class for those who prepare from PG to MCH, and I do take classes for DNP people here. And thanks for calling me. Kindly express my gratitude to Dr. E.K. Kapuzar, Professor E.K. Kapuzar, and thanks Dr. Anand for including me. I would like to participate in further academic meetings also, sir. Hope I have justified today's meeting. Thank you.
Thank you, Dr. Santosh. Thank you. Now we are closing today's session. Thank you. Thank you, everyone.